you're reaching way farther than the, maybe not for every patient, but it's definitely, it should be going beyond the subcutaneous tissue, right? So just try to make those associations, because once you understand that, you don't forget anymore, right? As long as you don't have to be really just like memorizing. If you really understand and make the connection, then it should just make sense, right? So, nope, other questions? Some of the students were asking me this morning about things to focus on the chapters, and I kind of told them, so they're going to be sending that in the chat. Elsevier was not allowing me to place the adaptive quizzing onto yesterday. I had been trying every day, so yesterday it worked again, so I was able to set up adaptive quizzing as well, so it should be there. Okay, let's get started here then. Medication administration, you guys already learned about all the different routes for medication administration, right? Did she show you like each one of the devices and pill cutters and pill crushers and all those things? Yes, no? No?
Not the pill cutters.
Okay. Oh, okay. And there's really no secret, okay? The pill cutter, you literally, it's just a little device. You put the pill right in the middle, and you just close it, and you know, as long as it's just one quick movement, it should cut the pill in half. And that's for cases that, for example, what you have available, it's a pill or a tablet that it's, let's say 5 milligrams, and you need to give 2.5, so you go ahead and you cut it in half, right? What do you do with the other half? Save it for later? Huh? What do you do, guys? You waste it, okay, thank you. And don't be afraid of saying the wrong stuff, or, you know. So you waste it. Okay. Same thing with medications that are controlled substances, okay? For example, you have a patient that is on a fentanyl drip. You have to change that drip every 24 hours. It expires, okay? So for the most part, they send a big syringe. For the most part, you're not going to use the full thing. So when it's time to change the syringe again, you have to waste that medication. But because it's a controlled, anything that is a controlled substance, you need a witness, okay? You have to go with a second nurse, and you're going to say, okay, this is how much I have left in the syringe. Let's say it's like 8 mLs that you have left in there. And that nurse verifies that it's 8 mLs, you discard that in front of the nurse, and then you both sign that that amount was discarded, okay? So that's the way it works. And this is to prevent, obviously, misuse of the medication, right? Many cases in the hospital, you guys would be surprised, especially in surgical areas, okay? There's a lot of CRNAs, anesthesiologists that, or you know, nurses that because they have so easy access to that kind of medication, unfortunately, you know, there's problems. So the hospital is extremely serious. All hospitals are extremely serious when it comes to wasting narcotics, okay? Let's talk a little bit about federal regulations. So all of those sectors are responsible for creating regulations related to medication legislation and its standards. So Pure Food and Drug Act was the first American law to create medication regulations. And they want to make sure that every medication is free of impure products. The FDA, what does the FDA do? make sure that they go through rigorous testing, right? So in 1993, they established the MedWatch program, which encouraged nurses to report medication errors, okay? This is still a problem nowadays. The culture is trying to change. You guys might hear a lot when you graduate, the just culture, which is the focus is not on punishing the nurse that committed a mistake, but working on ways to improve the processes to decrease the risk of that happening again. So it doesn't mean that nothing's gonna, it depends on the severity of the case, right, obviously. But, so the focus now is more in finding solutions to prevent medication errors than to actually punish the individual, okay? State and local regulations must match, right? But you cannot be having two different standards to federal regulations. And healthcare agencies establish individual policies to meet federal, state, and local regulation. What is the Nurse Practice X? Look that up. Yeah, right now. If you go even to your ebook and you search it up as Nurse Practice X, it will leave you right there. Law for governing nursing practice. So who does that protect? Nurses? Read it again. Read what does it entail? It protects the patient against nursing errors. Okay, so there's an establishment of this rules related to medication administration and among other things, and that's to protect the patient, not to protect the nurse. Okay, so the nurse doesn't do like whatever they feel like. They're following protocols, right? Okay, some of the pharmacological concepts here. The medication name, so you're gonna hear about the chemical name. The chemical name simply has to do with the description of the medication composition, okay? So it's the chemical name, it's what the medication is composed of. Now the generic name, it's the manufacturer who first develops the drug will assign the name, and then it is listed in the US Pharmacopoeia. Now the trade name is also known as the brand or the proprietary name, and that's the name in which the medication is going to be marketed for, right? Now they have whoever first discovers this drug, starts producing the drug, they have a patent, right? They have a certain time, and that can vary, okay? So that's why sometimes you can only find the brand name, and you cannot find the generic medication. It's because that company owns the right to keep producing a medication solo for a certain period of time. After that expires, other labs can start producing the same medication as the generic, okay? The classification, so when you guys start to fill out the forms in your clinicals, you're going to fill out the ATI medication form. Right on top, it's going to say classification. So what are you gonna put in there? It's what is the effect of the medication? What is the class of medication that med corresponds to? So let's say you're talking about dilantin, for example. What is the classification of dilantin? Look it up. Just put dilantin classification. Anticonvulsive, okay? So it's a medication for seizures. Okay, it doesn't mean, it does other things too, but that's the primary purpose for the medication. Okay, so that's the classification of the medication. It's related to the symptoms that the medication is going to relieve and the desired effect. Now, you guys did study about the different forms, right, in the skills lab, because I saw it in her PowerPoint that she mentioned that to you guys, so we don't need to go over that again. Now, the absorption. The absorption is the passage of medication molecules into the blood from the site of administration. So there's certain things that are going to affect how the medication is absorbed. First and foremost is going to be the route that you administer, right? Certain routes, they're going to fall into your bloodstream really quickly, right? And some other routes will be longer. So can you mention what route do you think is going to work the fastest? IV or intraosseous, for example. Okay, it goes straight into your bone marrow and it's almost instant the absorption. What is the slower route? Oral, topical, yes. So just remember that when you're reassessing a patient, you need to allow enough time for the medication to have its effect before you successfully assess whether the medication had the desired effect or not, right? So if you're giving PO medication, for example, for pain, most classic example, how long do you have to reassess that patient? Between 30 to an hour, okay? Now, if you're giving an IV pain medication, how long do you have to reassess? So 15 to 30, okay? So 15 to 30, 30 to an hour. Also, the ability of medication to dissolve, right? If the medication doesn't dissolve easily, it's not going to be easily absorbed, right? So when you have those extended release medication, did you guys learn that you cannot crush those medications? Perfect. So extended release, it is already done in a way that it's going to be releasing slowly for a long period of time. So the absorption, it's constant and or gradual and for a long period, right? And you don't crush exactly because you would be ruining the purpose of the medication, right? The blood flow to the site of the administration doesn't make sense. So if you don't have a good blood flow, circulation, for example, medication is not going to be easily absorbed, right? The body surface area, when a medication comes in contact with a large surface area, it is absorbed at a faster rate. And also lipid solubility. Okay, now when you're giving a medication, what is our brain mostly composed of? Fat, okay? So if you have a medication that is easily absorbed into fat tissue, that medication crosses the brain barrier, okay? So that's the difference. So if you hear medication, that medication crosses the brain barrier. So medications that, for example, crosses the brain barrier, something really simple, Benadryl. Don't you feel like dizzy, kind of? And that's because it has high lipid solubility. Okay. Now the distribution also has to do with the circulation, right? It's not going to be easily distributed if your patient has poor perfusion, right? It has to do also with membrane permeability. It's the ability of the medication to pass through all the tissues and the biological membranes of the organs. Again, blood-brain barrier only allows for fat-soluble medications to pass into the brain. And then protein binding is the degree to which a medication binds to serum protein, which an example here would be albumin, and that will affect the distribution of the medication. Okay, something that I really need you to remember, and you guys will hear about this all the time next semester when you learn pharmacology, but most drugs, I'm not saying all drugs, but most drugs are metabolized in the liver and excreted in urine. Okay, so most drugs metabolized in the liver and excreted in urine. But it could happen through different organs as well. So kidneys is the primary, liver for more like for to be metabolized. The bowel, if you're talking, you lose some medication through feces as well, right? Lungs, especially if it's a drug that it's inhaled, you're going to excrete that through the lungs as well, right? Does it make sense? And exocrine glands. Now, the chemical makeup of the medication, it's what's going to determine the organ of excretion. But as a general rule, that's what I mentioned in the beginning. Now, let's talk about the action of medications. So the therapeutic effect of a medication is exactly what you want the medication to achieve. That's a therapeutic effect, right? So dilantin, anti-seizure, anticonvulsant, you want the medication to stop seizures, okay? So that's the therapeutic effect. Now, the adverse effect, it's something that is unintended, undesirable, and many times unpredictable. Side effect, it's predictable, something that commonly happens to, it can happen, it's unavoidable, and it comes as a secondary effect of the medication. Now, toxic effect is the accumulation of that medication in the bloodstream, and then it ends up causing a reaction. Very commonly, something that causes respiratory distress, for example, right? It could be an accumulation of the medication in the bloodstream leading to respiratory distress, okay? Idiosyncratic reaction is the overreaction or underreaction or a different reaction from normal, okay? So those are the definitions. Now, everybody is different, right? The same medication, it won't have exactly the same effect on every single person because we have different metabolisms and we react to things differently. And it doesn't mean that a patient that wasn't allergic to something, all of a sudden they can become allergic to something. It can't happen, okay? So even if they've had it in the past, it doesn't mean that it's 100% sure that they won't have an allergic reaction. All of a sudden, they can develop or have a different reaction than what they used to. Okay, I used to take a medication, it did nothing for me, stopped for some time, went back to using the medication, many side effects that I had never experienced. So this happened to me. Okay, so it's the same medication, I'm the same person, but now this medication has a different effect on my body. Okay, so it's this is something that we have to keep in mind as nurses to better assist our patients, right? Because if they're reporting something, oh, I've never felt that before, no. Oh, it's probably nothing. No, it's not like that. Okay, you gotta keep an eye on all those things. Now, an allergic reaction is unpredictable response to a medication. Medication interactions. One medication modifies the action of another. It can either modify, it can decrease the effects of another medication, or it can increase, potentialize the effects, okay? And it's not only medication. With medication, but medication and food, okay? You're going to learn that grapefruit, it's a fruit that interacts with a lot of different medications, so you have to be really careful with that, okay? Medication tolerance. So the same medication that you have been giving for the last week, for example, you have been giving 5 milligrams of, let's say 2 milligrams of morphine, and this patient the pain was just under control on 2 milligrams for the past week. This week, all of a sudden, 2 milligrams, it's not really keeping the pain under control. This patient could be developing tolerance to the medication. Now you need a higher amount of medication to reach the same desired effect, okay? Medication dependence, those especially with any narcotics, right? Opioids, medications to sleep, for example. It can either physical dependence, your body really becomes used to the medication and needs it, or it could be psychological as well. You feel like you cannot do it without that medication, right? You need the medication to feel well, or it could be both, honestly, right? It could be both of them. Okay, you're caring for a patient who has diabetes complicated by kidney disease. You need to make a detailed assessment when administering medications because this patient may experience problems with A, B, C, or D. Yeah, so it's excreted in the kidneys, right? If the patient is having kidney disease, you're most likely going to have problems there. Okay, a post-operative patient is receiving morphine sulfate via PCA pump. The nurse assesses that the patient's respirations are depressed. The effects are classified as toxic. Okay, it could be an accumulation of the medication in the bloodstream and it's causing toxic effects, in this case, respiratory distress. Let's talk about timing of medication and those responses. Let's talk about something that's called the therapeutic range. So the therapeutic range occurs between the minimal effective concentration and the toxic concentration. So somewhere in between there is the therapeutic range. Okay, so it cannot be low enough that it's not going to reach the desired effect, and it cannot be high enough that it's going to reach toxic levels, right? Now, a peak level, it's the highest serum concentration level. So let's say, I know for certain medications, you guys know, it's ototoxic, nephrotoxic, right? So you have to be checking the levels of the medication in your body so you can make sure that you're not at toxic levels, for example, that's going to be damaging your kidneys or your hearing or all those things. So there's certain medications that we have to be checking. Vilantin is one of them. Gentamicin is another one. Gentamicin is highly ototoxic. And so before we give, I'm just gonna give you an example here. Before we give gentamicin, the third dose, we have to check for peak and trough levels, okay? So the peak level, we draw blood an hour after the patient. You don't have to write that down because I'm not gonna ask you that. I just needed to understand the concept. After I'm done infusing that gentamicin, I turn the pump off. An hour later, I'm collecting labs to see what is the peak of the medication. The trough, I'm going to draw 30 minutes before I start to administer my dose because it's going to be at its lowest level of concentration, okay? So, and there is a range. So then you see if it's out of range. Is it too low? Does the dose have to be increased? Is it too high? Does the dose have to be decreased? And whenever we make adjustments to the dose, usually we have to draw labs again on the third dose that it's giving the new dosage again, okay? So you got it? What is peak and trough? Peak at the highest level of concentration, so serum concentration, and the trough is the lowest. Okay, now the biological half-life. So you give this drug if you read the instructions that come with every medication, it's going to tell you what is the half-life, okay? So whatever the half-life is, let's say that you're giving a medication that has a half-life of 6 hours. Let's say that you gave 800 milligrams, so at 6 hours, you know that that medication is going to be at half concentration, so it's going to be at 400 milligrams. Another 6 hours, you're gonna have how much left? So forth, so on, okay? So that's how they come up with how many, every how many hours can you administer a certain medication. It has to do with the half-life, okay? So let's say that you have, you're giving a medication that's 16 milligrams and the half-life is 2 hours. After 2 hours, what is your concentration? 8 milligrams. After another 2 hours? 4 milligrams, so forth. So, okay, so you guys do get it. And that comes patient teaching. You really want to make sure that your patient understands that. So they understand that's why you cannot take before this time, right? And that's why it's best to take between this and this time. And that's lots of patient education have to do with medication administration, okay? Because if they don't understand their medication regimen, they're most likely not to succeed in their treatment, and those will be the patients coming back frequently to the hospitals, okay? So they really need to understand what the medication is for, when do they need to take, they need to understand possible side effects, okay? And you guys don't have to be so concerned about, yes, you're gonna learn your meds here. I can promise you it's going to be impossible to remember every single medication in the drug book once you go to your floors and you start working. You can't. It's just too many medications out there. But one thing that, really hospitals have, or the platforms that hospitals carry now, they do a pretty good job. For example, you're going to give a medication now, you're not sure what the medication is, or you're not sure about the side effects. You double click or right click on the medication, it pulls the whole reference. So there's no excuse for you to be administering things that you do not know. It is not acceptable for nurses to administer medications that they don't know what it's for, that they don't know safe range for administration, and they don't know side effects. Because if your patient starts having any of those side effects, you're not even going to know that it was related to the medication. So quickly pull that up and take just scan through the whole thing so you can start to understand. And obviously the medications that you give all the time, there's certain areas that they use more of a certain type of medication. Those you're gonna get to know better, right? But just remember that it's never okay to administer something that you're not familiar with without taking a quick look before, okay? Oh, it wasn't a rush. That makes a difference between possibly killing someone or not, okay? So really quick, just take a look at the reference guide. You learned about sublingual administration, right, umbilical. Those are quick routes as well. This area is well vascularized, right? So it gets absorbed really quickly as well. So if you have to give instructions for a patient that's going to take a buccal medication, what are you going to tell them? Mhm. Hmm? Okay, and don't crunch, don't chew as well. Okay, same thing for the sublingual, right? Just let it absorb. For the parenteral route, you have four main sites of injection. You have the intradermal. The injection is right into the dermis, just under the epidermis, right? Classical example of that is TB test, okay, or your allergy test, for example, okay? Those are the two most common ones. Subcutaneous, it's going where? Into the fat tissue. So any area that we collect fat, I know some of you cannot relate, but any area that collects fat, okay? Love handles, stomach, the most common one. Back fat, the back of the arm, so you just, oh, where do I inject? Just pick up the patient's arm like this, whatever hangs, that's exactly where you're going to apply the injection, okay? And even like inner thighs, okay? Those are the most common areas. Epidural. Epidural, it's the needle that goes straight into the epidural space, right? And that's for what kind of anesthesia? Okay, but what is the name of the type of anesthesia? I know we talked about this. What kinds of anesthesia do we have, guys? Is that local though? General, your patient's out, dead, okay, basically. Okay, so it's paralyzing a certain area, right? So it's a region, it's a directional anesthesia. Okay, intrathecal catheter that's placed under the subarachnoid space on one of the ventricles of the brain. Intraosseous, that goes straight into the bone marrow. Those, that's not very common. It might be used when somebody is trying to get an IV and they can't, or severe cases of trauma, for example. EMTs will use that, right? It's just like one huge, it's a choker, right? That goes straight into the bone, and you administer medications there. And it's a great way, if your patient is sick enough, they probably won't even realize at that point. But if they are all there, it's extremely painful, right? Intraperitoneal, what is the peritoneum? What is the peritoneum, guys? Andy? Where? Where? Where is the peritoneum? It's in the abdominal cavity, okay? So abdominal cavity or the peritoneal cavity. Intrapleural. And intra-arterial, that goes straight into the arteries. The only time that you're going to do that, we usually don't do it, okay? It's for arterial clots, and that's usually not nursing that's going to be administering. Topical administration, you have the skin, you have the mucous membranes, inhalation route, intraocular routes. The mucus can be the eyes, anybody cavities such as suppositories, flushing the bladder, spraying your medication into the body such as the nose and the throat. You guys have reviewed all this, I'm just going over like really quick, right? Systems of medication measurement. Yay, your dosage calculation. guys are loving it, right? That's what I heard. You love to calculate dosage? You do? Yeah. Okay, I suggest it becomes your best friend because you're gonna need that for life. It doesn't matter what method you use, it just stick to what you like the most. And as long as you get the right answer, it doesn't matter the method, right? Just, I was telling some of the students, I cannot use dimensional analysis. I did not learn dimensional analysis growing up in math. It's not my forte, right? I do not like math. As a nurse, you have to learn your methods, you have to stick to them because you cannot get incorrect dosages, right? You can kill someone. So as long as you stick to your methods and you're getting the right calculation, you're fine. If you're in doubt in practice, go and double check with someone before you administer, okay? Now the metric system is the most logically organized. You use meters, liters, gram. Never use a trailing zero. Why? Can easily get confused, okay? Especially if you're, your little dot there, somebody doesn't see it, everybody gets it confused, it changes the dose completely, right? So in multiplication, the decimal point moves to the left or the right? In multiplication. It moves to the right. And in division, it moves to the left. Okay, so always use the full number, 0.0 something, 0.25, whatever the case is. Remember that for IV, when you're talking about drops, you cannot administer 33.5 drops or 33.2 drops. It has to be whole number. So you're going to either round up or down according to the
nearest whole number.
exactly, okay? So if it's like 33.4, it's going to be 33. Your 33.51 is 34, okay? So don't get confused on that on your exam. Do not use, you have to use whole number when you're talking about drops, okay? And you will see there to use whole number. The household system is the most familiar to individuals, right? You say you take a teaspoon or a tablespoon, and so it's the most familiar. The only problem with that is the inaccuracy, okay? What a teaspoon might be for me, it might not be for someone else, right? So they might put a drop in the teaspoon, and that's a teaspoon for them. And for me, it's like filled all the way up to the top, right? So that might be inaccurate, okay? For solutions, when a solid is dissolved in fluid, concentration is expressed as all those things, okay? It could be a percentage of a solution, so when you're talking about D10, 10%, and a quarter in S, okay? So then you're talking about percentages of solution. By the way, I told you guys this, and I'm gonna say it again. Do not let yourselves be confused by the type of solution. You don't need to put that into the equation when you're calculating the dosage that you need. It doesn't matter if the medication is mixed in this water bottle here, or in that other solution, or in the coffee that somebody else is taking. It doesn't affect in anything as far as dosage calculation, right? What it matters is the volume that you're going to have to administer in the time that you're going to have to run that medication over, okay? So those are the things that you need to take into consideration. So you might have information that you don't need to use, so don't let yourself be confused, okay? Let's talk about medical errors. Medical error is the third leading cause of death in the United States. Okay? And that includes from misdiagnosing to actually administering something wrong, giving the wrong medication. It includes everything related to medical errors, but it is the third leading cause. So that's an awful high. It's about 250,000 deaths a year just by medical error. Okay, I don't know about you, but I don't want to be in that statistic of someone causing something like that. Have you guys heard about that case from a nurse? It was just like a couple of years ago, Radonda Bot, right? If you heard about that case, I don't know if you read the whole thing, how her error happened, but she was going to administer Versed. Versed is a medication that it relaxes the patient, and at the same time it causes amnesia. So if they have to go to a procedure, for example, they are claustrophobic and they have to get into an MRI machine. You give Versed, it helps them relax, and after the fact, they won't even remember that happened. Okay, they don't recall the procedure. They do use a lot of for GI procedures, colonoscopies, endoscopies, things like that. So that patient, 75-year-old lady, she was there and she needed an MRI, and the nurse went to the Pyxis, and instead of removing Versed, starts with the VE, she removed vecuronium. Vecuronium is a paralytic drug. It causes your muscles to stop, basically, so she couldn't breathe. But she doesn't lose consciousness. That's the worst thing, okay? Because it causes paralysis of the respiratory muscles, but it doesn't cause the patient to lose consciousness, okay? So that medication is used a lot for intubation because you don't want the patients to be fighting, right? So you quickly paralyze, intubate really quick, and then that's that, and machine is breathing for the patient, and it's all good, right? That's the intent of the medication. So they both start with a V. So the pharmacist had not verified the order for the Versed, so it was not in the patient's profile. So what she had to do, she had to override the medication. And when you override the medication, you're always at triple risk of committing a mistake, right? So you really have to be extremely careful, double check, triple check, make sure that this is exactly what you want to give. And it was asking, the machine was asking, are you sure you want to give this? She was overriding the medication, yes. Just go ahead, and I believe that she probably didn't even scan the medication because it was not even part of the patient's profile. And she administered that medication. Patient had went into respiratory arrest, right? And they were able to bring her back, but she ended up dying the following day. The family decided to withdraw support. Well, this nurse she got a lot of charges, different charges. She lost her license. The latest I know is she was sentenced to 5 years, but somehow I think she's on 2 years of probation now. And but the worst thing is having to live with that, right? And all the pressure. Imagine, like, she became nationally known, like everywhere she goes now, she's known as the nurse who killed the poor lady, right? I'm sure she didn't go to her shift that day and she was intending to administer the wrong medication and kill someone, right? I'm sure it was not the case, but it was due to probably many things between, being tired but bottom line is being careless, like reckless type of behavior, right? Because you have to break a lot of safety measures to get there, right? So this is what we're trying to avoid, and this is why medication errors is something that you have to do everything that you can to avoid happening, okay? That's why you do how many checks before you give a medication? 3 checks. When is the first check happening? You're taking it out of the machine, you're checking your Pyxis, which Pyxis is the brand name, okay? Everybody call it the Pyxis, but it's actually an automated something device we're gonna say here, but everybody call it the Pyxis. It's just one of those things that indwelling catheter is a Foley catheter. It was a brand and it became like the known name, okay? So it's one of those things. So first one, when you're removing the medication. Second one, so you finish removing all the medications, now you're double checking again against the MAR, medication administration record, right? Against the MAR with what you got out, right? So you got this one out, okay, check. Second one, you're double checking for the what? The name of the medication, the dosage, the route, all of those things, okay? Medications that need special consideration, things that you're going to be checking before you administer. For example, beta blockers. Most beta blockers, they're gonna say, hold medication if systolic less than 90 and pulse less than 60. So you know that you're going to have to check the blood pressure and the pulse before you're able to give the medication. So that medication, you wanna keep it separate from everything else. So when you are in the patient's room, you don't forget about it, you open it up and you give it and you forget to check. Does it make sense? Same thing with medications that cause respiratory, for example, you're giving morphine. You're going to have to check for the respiratory rate and you have to write down what the respiratory rate was. If it's a 10, you're not going to give it because you know that the medication most likely will depress even more, right? So unless you're talking about a hospice patient, that's a different story, but I'm talking in general, okay? So that's your second check right there. And now your third check is happening where? In the patient's room, okay? Inside the patient's room right before you give it. So checking 2 patient identifiers, name, date of birth, right? And now you're opening up everything, you're scanning each one of the medications, and just remember, if the system realizes, you know, this medication is not due now, it's going to ask you, why are you giving it now? This medication is not the right dose, why are you giving? And you have to justify it, that all stays recorded there, right? So that's why I'm saying, like, it's a lot of breaches in security when you get to a point of giving a medication like that to someone, because the system will alert you. We didn't have that in the past at all. We didn't even have Pyxis, right? So it's incredible how technology has advanced to try to decrease all of these mistakes from happening, okay? So don't get complacent. Don't try to jump important steps in administering medication. Now, your book and NCLEX will tell you how many patients at a time do you prepare medications for. 1 patient at a time. You will see that for the most part, that's not what happens in the field, okay? Because especially when you work in a med-surg floor, that you have many patients that are taking many medications, it becomes really hard to go back and forth and take medication for 1 patient at a time, especially when you have all 9 o'clocks due, right? How are you gonna be administering? By the way, you have an hour window to administer anything because everybody knows that it's impossible to be in all places at the same time, right? But I don't want you to get, ooh, like they're not doing what they're supposed to do. Well, they're not according to the book, according to, you know, as it is the safest way, is to really have medication for one patient at a time. But you will develop your own methods if you have to prepare for more than one patient, right? Put in different bags or label, always label for the different patients, okay? So I want you to pay attention to those things when you go to your clinicals, okay? So we're not talking about calculations because you guys already went over this. Pediatric doses always require special caution just because it's so much easier. Any mistake can be really serious, right? And they're usually calculated based on weight. What weight do we use? Is it pounds? Always kilograms. It's always the metric system, okay? So you most likely always be giving questions using pounds. You have to transform it into kilograms, okay? Okay. Healthcare providers' role. You have the prescribers. The prescriber can be a physician, can be a nurse practitioner, a physician assistant, even dentist sometimes, right? The types of orders, you have a written order, by hand. Those, unless you're having downtime in a system, it has pretty much, or if you go work in really remote areas, but they don't have everything electronic, I haven't seen anything by hand for many, many years now, right? So it's going to be electronic for the most part. You have verbal orders, so let's say that I'm talking to, so in the NICU, I'll give you the example because I work there. Let's say I get a lab bag that it's critical. I might call the nurse practitioner that it's in-house 24/7, and he or she might give me an order. It's going to be a verbal order. Well, if it's by telephone, it's going to be a telephone order. But sometimes they're in person, and they might say, you know what, go ahead and start this, or go ahead and order an X-ray, or and they might not be the ones ideally. It's them that should be putting the order. Okay, I try not to place the order. I say, so you're going to place the order, okay? Because it is their responsibility. But sometimes if they're too busy with too many things, sometimes they're going to a delivery and they might say, just go ahead and enter the order. Then you enter the order, they have to go in immediately, as soon as possible. They have to validate the order, and they have their electronic signature that they really did order that, okay? And in that case, you have to stay on their case to make sure that they are really signing for those orders, okay? Now, if you're placing an order on the telephone, on paper we used to do the VORB, verbal order readback, okay? You had to repeat, so you always repeat what they're saying. So you're saying that you want ampicillin 250 milligrams IV Q12 hours. They're gonna say yes or no. You have to read back to make sure that there's really an understanding. You are on the same page. You didn't understand something else. Okay? So, and you have to document that. Okay? Verbal order given, right back. Abbreviation. Abbreviations can cause many mistakes. There is some abbreviations that are unacceptable because they resemble something else and it can lead people to getting confused. In the units, you're going to see close to the fixes abbreviations that are not acceptable. Okay? So we used to put, like for insulin, for example, let's say 5U for units. That's no longer, for a long time now, accepted because it leads to too many mistakes. So it has to be written out units, okay? will become familiarized with the prohibited and abbreviations. You have that in your book, actually. You have a table of unacceptable abbreviations. I would definitely take a look at that. I don't need you to know each one of them, but I definitely want you to take a look at that. Types of orders. I know that you saw this in the skills lab as well. So standing orders, those are routine orders. That's what you have at once it's prescribed, that order stands until it expires or somebody discontinues the order, right? So if it says ampicillin 250 milligrams IV give 12 hours, it's usually going to say for how many days? For 5 days. So after 5 days, so that's a standing order for those 5 days, a routine order, okay? Now, a PRN order, very commonly for pain medications, right? So you might have morphine, 1 milligram, IV, Q, 4 hours, PRN for pain, okay? Now, does it mean that you're giving every 4 hours? You're just giving if the patient needs it or requests it, okay? So PRN, but can you give, let's say they asked 2 hours ago and they're asking again, it's a PRN order. Would you be able to give it in this case? No, because it hasn't been 4 hours yet, okay? Doesn't mean that you're not gonna do anything about it, right? We're gonna look for any other options or maybe ask for something additionally, but you wouldn't be able to give that same medication. Single time orders, you're going to see written down times 1. Times 1 means 1 dose only, okay? Times 2 doses only, okay? So if you see times something, or if you see 1 dose, it's just a single dose, okay? Stat orders, it means immediately, it's right now, okay? It has to be given as soon as you get a hold of that medication, and you're calling the pharmacy to say that you have this stat medication, okay? If you, in case you have it in your PICSs and the pharmacist has not verified, so it's not part of the patient's profile medication, you can go ahead and override it again, extra carefully. Now means it's urgent, but it's not emergent, right? So you should be giving within 90 minutes, okay? And then you have prescriptions. We have the sample of a prescription here. I'm gonna be honest with you, you see less and less of this every day. Now, prescriptions are mostly sent electronically, right? Straight to the pharmacy, because what happens when people get this? They misplace, they forget where they put it, and it's not as safe. People can modify, can alter as well, right? So what you see is that most providers now, they ask you, what pharmacy do you use? And then they send that prescription electronically straight to the pharmacy, and you just go and pick it up, right? You rarely see anybody carrying a prescription anymore. What is the pharmacy role? The pharmacist's role? As soon as they receive an order, they have to check that order, okay? So they have to check if it's appropriate or not. They have to check that it's within the range that it should be. If there's a huge discrepancy, they should be calling the prescriber to double check, or they might call the nurse, and then that gets placed to the patient's profile, okay? Now, the nurse's role. The nurse's role is to determine that medications were ordered correctly. I've seen quite a few mistakes from pharmacists in my life where medications were diluted incorrectly, and if you don't pay attention, you end up committing the mistake because you're the one administering it. So you double check everything, especially with my babies. I make sure that what is the safe dose range here. I literally get their weight and I calculate to make sure that what is ordered is within range, right? And then when you get the medication, again, you're going to see it was diluted in what, so how much volume of the medication should be in there before you administer. You're going to monitor for any side effects. So if you know that this medication is a vasoconstrictor, when you see that the heart rate is increasing a little bit, you know that it's a common side effect of the medication, right? So you're not running around freaking out because you're thinking that something is very wrong with your patients, right? But you need to know how this medication acts. And as I said, you're not obliged to know every single medication in the drug book, but you do have the responsibility of checking. If you're not familiarized with something before you give it, you have to quickly check, just a quick reference there. Provide patient teaching. So, Mr. Jones, I'm about to give you your insulin. Do you know what is insulin for? Oh yeah, it's for my diabetes. I've been using that for 30 years. Okay, so can you tell me, I'm about to give it. You have your tray here. Are you ready to eat? Oh yeah, I'm hungry. I'm not gonna eat now. Okay, so if you're not gonna eat now, I cannot give you your insulin now because you're gonna cause your patient to go into hypoglycemia, right? Okay, do you know the signs and symptoms of hypoglycemia? Do you know which site do you use to administer that insulin? Oh, you know, I kind of like just vary a little bit. Perfect. You know that they know what they need to be doing because you know that they should be rotating the administration site at every single dose given, right? What's going to happen if you administer on the same side all the time? Scar tissue, you can have fat atrophy. You can create pockets of medication, it's not getting systemically absorbed, right? So it should be rotated. And not only talking about how painful the area is going to be if you keep applying to the same area all the time, right? Now, can you delegate medication administration to your patient care assistant? No, medication can never be delegated to anyone. It's your responsibility, okay? So simple question here, don't ever delegate medication to anyone else. Okay, this is the famous Bixens, right? Which is actually an automatic medication dispensing system. You're never going to hear anybody say this word, okay? Everybody's gonna say the pieces. So I'm just saving you. But if you ever see this somewhere, then you know what it is. Well, what is an automatic medication? Okay, yeah. It automatically dispenses medications. So the Pixis is a very, very smart machine. They keep all the different medications in the different pockets. So when you're clicking on your patient's profile, you click on the medications you want to remove, it's going to, in order, pop out the drawers, and it's going to tell you the drawer number that the medication is on. Now, again, don't blindly trust this. This is people that restock this machine. So it's not impossible that they put the medication in the wrong pocket, right? So, but you get the medication, just double check, but it's a very, very convenient, smart machine. You're able to keep a lot of medications on the floor now without having to wait for pharmacy for everything. Medication errors. These refer to any preventable events that may cause inappropriate medication use or jeopardize patient safety. If you commit a mistake, what is the very first thing that you're going to do? Check the patient, guys. It's always, always, always going through the nursing process. Assessment, assessment, assessment. What is the patient doing? How is the patient reacting? Is the patient okay or not? Because when you call someone to let them know about what happened, they're gonna wanna know how's your patient. So you need to assess them even before you call, otherwise you look like you're not really on top of things, right? So if the patient is stable, or when the patient is stable, you're going to report the incident. Now it is your responsibility to report if a medication error happens, okay? Now you're going to prepare a file or an occurrence or incident report. This is not part of the medical record, okay? I just want you to keep, you're not going to be there on your chart and you're gonna say, I administered the wrong medication. This is terrible legally, okay? Every institution will have their own system, but they have usually a reporting system that it's besides the medical record. So you create an incident report. In that incident report, you can go and put everything in details, and it's not part of the medical record. Okay, that means if this goes to court, they don't have access to that. Okay, it doesn't mean that you're trying to cover things up, but sometimes in describing every single event, it can be very problematic legally, okay? Now, same thing for falls, for example. Anything that happens out of the ordinary, it wasn't expected to happen, you're not going to omit in the chart that the patient had a fall, sustained a fall. You're going to put in that a very brief, patient arrived to the room, patient was on the floor, upon assessment, patient seems alert and oriented, no bruises, no apparent broken bones, called so-and-so, ordered an MRI. That's that, okay? Now, on your incident report, if you feel like, oh, the CNA was there, they had just walked the patient said that they wanted to get in bed themselves, you think like there was maybe some sort of fault somewhere, you're not writing any of that in the chart. You can write it in the incident report, okay? It gets investigated internally, but it doesn't go into the patient's charts. Does it make sense? Okay. You also have to report near misses and any incident that may cause harm, or incidents that cause no harm to the patient. So you're going to be reporting what is a near miss. Something that could have harmed the patient, but it didn't. Near miss, something that could have happened, but it ended up not happening by the grace of God, right? So those are near misses, okay? During transitions of care, this is something very important, so I need you to remember this. Reconciliation of medication, okay? So medication reconciliation is something that happens at every transition of care. So a patient is coming into the ER, medication reconciliation is done. What does that entail? Checking all their current medications. Everything that you're taking at home, go ahead and tell me. And then checking against what it's being prescribed, so you make sure that you're not giving double of the same medication, because that's a problem. Like a patient goes to a doctor prescribes a medication. This patient goes to another doctor, a specialist, for example. Now that specialist doesn't know that this patient is taking this medication, and now he wants to prescribe the same thing, and all of a sudden the patient is taking two of the same thing. Okay? So this is where medication reconciliation is so important. So it's done at every single transition of care. This patient came to the ER, that's done in the ER. This patient is going back up to the floor, it's done in the floor again. This patient, before it gets transferred home, medication reconciliation is done again. And with that, pharmacists, they also check for interaction of medications. Okay, a lot of times, you know, physicians know every single medication that interacts with everything. They don't know. Okay, so that's the job of the pharmacist as well. They should run a report, a list, and find out if this medication interacts with that one, or doc, this one cannot be taken with that one, so they decide for something else. Okay, so medication reconciliation, remember, done at every transition of care. If you experience a problem reading a physician's medication order, what is the most appropriate action to do? Call the physician, or you call the pharmacist? Huh? Physician. Some of you were like that. Okay. So, medication, I told you having the knowledge is very important, but even if you don't have the knowledge of all the medications, you need to make use of the resources, right? You need to understand why is this medication being prescribed. So if somebody gets you, ask yourself, like even like from the very first clinical that you go to, okay, what is this medication for? You're going back home and you're doing your medication forms, and you say, okay, this patient has congestive heart failure, and they are on a diuretic. How is the diuretic going to help the congestive heart failure? Start asking yourself questions of why do you think this patient is on the medication that they're on. This is going to help you develop that critical thinking, okay? Understand why the medication is prescribed. And then if you don't understand why, talk to your instructors. You can go ahead and ask, hey, I didn't understand, like this patient has this, why is this patient taking this on the medication? I didn't see anything as a past medical history, why they would be taking this medication, okay? So this is how you start to develop critical thinking. Now the experience, it comes with the your clinical experience, your psychomotor, that's why we do skills lab, right? So you can start to practice. Obviously, the more you practice, the better you're going to be. I can promise you that most likely you're going to be shaking on that first injection that you're going to give in the hospital. Don't let that stop you, okay? Because the more you face it, don't be the one trying to hide in the corner. The more you get exposed, the more things you get to do, the faster you're going to feel better about it. The more exposure you have, the more proficient you're going to get. And that's why you have instructors there to back you up, and you can always ask for assistance, okay? Before you go to a room to administer medication, for example, play those steps that you performed in the skills lab in your mind before you go into the room, okay? Go prepared already. What questions am I gonna ask? So you're going to give a Lovenol, so you're going to give insulin. You go to the patient's room, hello, Mr. So-and-so, Miss So-and-so, you're there, the nurse is going to ask for permission for you to administer the medication, and you're going to say, okay, I'm here to administer whatever medication. Where do you want to receive it? Ask them, and they might say, oh, give me here. Okay, where was the last place that you received? Oh, okay, so now you know, and then play in your mind, what are the steps? What do I have to do? Cleaning up the skin, removing the cap of the needle, all those things. Play the steps so you don't get there and you start to panic, right? When you play the steps, you're kind of like preparing yourself to do what you're going to do. Be disciplined, take your time. be responsible and accountable. If you committed a mistake, just go ahead and assume it, and and go from there. And knowing the standards of nursing practice and following it will ensure patient safety as well, or at least decrease by a lot the risk of you committing a mistake. Now, I know that your book talks about 7 rights. Some authors talk about 11 rights when it comes to medication administration, okay? The book talks about 7. I noticed that Ms. Mayfield had 5 in her slides, okay? But patient medication rights. So the patient has the right to receive the right medication, the right dose. It has to be for them, right? You cannot give someone else's medication. The right route, the right time, and now it includes those other 2 as well, which is the right documentation and the right indication. Maintaining patients' rights is extremely important. Anything that you're doing different than this, you're infringing their rights. If you were a family member, it would not be okay if somebody failed to do one of these things. If you were for yourself, it would not be okay, right? So we have the responsibility to guarantee that these things are done. Now, if a patient refuses a medication, what do you do? Somebody said talk to them? Did I hear you talk to them?
You can,
Okay.
but if the patient doesn't want anything, that's their right.
So that where talking to them actually helps, because you need to understand why they don't want it, okay? It could be maybe a misunderstanding. It could be something that the patient, they might be confused. They might think that you're there like to give something that's going to kill them. They might think that they might have a lot of misconceptions, and this is your chance to clarify anything and maybe explain the importance of them taking the medication at that time. Now, if they continue to refuse, obviously you're not going to force anything. It is their right to refuse, and you're just going to document the refusal and the reason, what they said, okay? But you don't ever force anything on anyone. You're going to learn later that's if you actually force somebody to take it, it's considered to be battery, okay? So it's something to keep in mind. So you are, as a nurse, legally required to document the medications that are administered to patients. The nurse is mandated to document which of the following: a medication you're going to document before administering it, after administering it, the rationale for administering it, or the prescriber's rationale for administering it. So you're going to Mr. Jones' room here. You have all the medications and you double checked everything. Do you actually document before you administer, after you administer, the rationale or the prescriber's rationale? Never before. What happens if you're ready to approve it, the patient refuses? What happens if you, for example, you're going to give them morphine and you realize their respirations are 10 and you're going to withhold the medication? Or that beta blocker that I told you, you realize their pulse is 55. So it doesn't meet criteria for you administering, and all of a sudden you're already documented as given. And for you to go back and retract, it's going to look horrible. It looks like falsification of documentation. If you document something that you haven't done, you're lying. It's falsification of documentation, right? So always after. Here for the assessment part, you're going to be go ahead and take 5-minute break. Well, everybody seems excited about it. Do you want to keep going and play a little Kahoot? Yeah? Okay. Let's do that. Okay. Part of the nursing process, assessment. Again, you're going to consider the patient's preferences and values. You're going to assess for patient experiences, history of medications, any allergies, all types of medications that they're taking, including herbal medications. Remember what could be the problem with herbal? Interactions, right? So some herbal medications can either decrease the effect of medication or potentialize. So you gotta be careful with that. Patients' perceptual or coordination problems, you also must consider things such as accessibility to the drugs, right? What is the financial status of the patient? Are they insured, uninsured? It doesn't matter for us from the care point of view, but when it comes to them obtaining the resources they need, that is really important, right? What is the patient's current condition? What is their attitude about taking medication? Factors that will interfere with the adherence to the medication therapy. That's what I was talking about. You can have a patient that gets prescribed, let's say insulin. The patient is uninsured. Do you know how much each vial of insulin costs? $170 to $300 each vial. And they use, in average, 2 to 3 vials a month. So let's say that we're talking about the $300 one, 3 vials a month, we're talking about $900. Who's gonna be able to afford that? Even if you have a good job, $900 a month in insulin alone, it's really hard to do, right? So you gotta look at all the factors that are going to affect the adherence to medication therapy. Now, there are a few resources out there, certain cards that will give discounts, right? You can connect to the pharmacist so they can try to find those resources as well. Case management, they can work with the patient, but you gotta make sure that they're leaving the hospital with a regimen that they're gonna be able to follow. Look for patients' learning needs, okay? What is the best way for you to assess that this patient is understanding what you're saying? Teach back, right? Start by teaching the patient the most important information first. Aren't you more likely to absorb things in the beginning, and then towards the end you're kind of like getting lost already, right? So you start lecture like, ooh, I got this. Towards the end of the lecture, you're like, oh, what is she talking about, right? So with patients, it's the same thing. The other thing is like, you don't wait until they're ready to go home to start teaching. Teaching has to be occurring from the moment they get admitted, because once they know that they're going home, they don't care about anything. Do you understand? Yeah. Okay. So you don't wait to start teaching. Teaching has to occur from the get-go. And then you teach them, if they use many medications, something that's very effective is the use of appeal blocks. So you can instruct maybe a family member, especially like for elderly patients that, with vision problems and things like that. A family member can go one day of the week and fill out the pill box for the whole week, right? And that's much easier for them to just remove what they need to take, and it's already all there. You can give handouts as well, okay? But just remember, teach back, especially when you want them to do something. Injection, insulin administration, for example. Ask them to show you how to do it, so you understand whether they really got it or not. These are some of the nursing diagnoses that could be used, related to medication administration. Now, what is considered to be polypharmacy? Taking a lot of medications, and by a lot, how many? Okay, but polypharmacy usually refers to a certain number of medication that they're taking. And you would be surprised that it's not that many. It's anyone that's taking 5 or more medications in a day. It's considered to be polypharmacy. Okay, a lot of patients take more than 5 medications a day. Okay, and that increases the chance of them committing mistakes, taking the medication more than once, or taking the wrong medication, right? The more medications you have to take, the more confused you can get. Oh, did I take it? Can't remember if I got that one or not. Maybe I should take it again, or maybe I already took it, so they don't take it, you know? So there's a lot of mistakes that could happen related to polypharmacy. You're going to set goals with the patient and see what is effective for them, set priorities with them, and involve family members in this case, bless you. So involve family members as well. Teamwork, who's going to be key here? Besides you, the nurse. The nurse is in everything, right? But besides the nurse in this case? UAPs. What else? Who else? The prescriber, the pharmacist, right? So you have to work closely, even your case managers here, if the patient needs some sort of resources, they can help and see what is available out there to assist them. Special considerations, obviously infant, children, older adults, the two end of the spectrum, right? Or the beginning and the end. Because it's more risky. They absorb and metabolize medications differently, especially the elderly. So you're going to see where is that? I guess you should have a slide that talks about the effects of aging on the medication. You have that in your book. I probably removed that slide because I know that Dr. Milius covers that in general. Okay, so we're not talking about the same things in here, but your metabolism as you age gets slower, right? You could have effects not only on the way that you metabolize, but also excretion. You usually need smaller doses to reach the same effect like for an older person, okay? But I know that she talks about this in general. We have talked about these things here, and this is all the things that you guys already reviewed in the skills lab, okay? So if the slides are there available, you have the different types of syringes there as well. You guys saw the lure lock, the non-lure? Okay, so the lure refers to this part, right? This is the lure lock, this is non-lure. It doesn't have the little part, it's just it screws it on with the needle. You saw the carpet duct? No. You can ask her to show you during open lab, the carpet duct and you're not gonna use it for checkups. You guys got your break and echo, right? You didn't? Oh, okay. You guys gotta let me know when, so I can ask Ms. Ollie to order that. If you can make a little list, that would be great. So you learned how to withdraw medication, right? So following exactly that, remember it should be sitting on the table, you're not holding the vial because you can poke yourself, right? Recapping the needle, when do you recap the needle? Never. So you prepare a medication and you're not ready to give it to your patient, you're not going to recap it? Okay, so let me just clarify here. You can't recap the needle if you're just preparing the medication, you're not ready to give. The medication has not touched the patient. You can recap using the scoop up method, okay? Don't ever touch the tip of the needle, right? First, because you're going to poke yourself. Second, you're contaminating. So in that situation, you can recap the needle, scoop up method, but once the needle has touched the patient, you don't ever, ever, ever recap the needle, okay? So if it doesn't have the little safety device that you can activate, it goes straight into the sharps container. You don't sit back on the table as well, because guess what? You're going to get distracted, and once you're cleaning up everything, before you see it, you got poked, okay? And it's not fun to get poked, ever, but especially when the needle has already touched your patient, okay? Because you don't ever know what the carry, right? So, insulin, you learn how to mix insulins, right? Which one you inject air first, which one you withdraw from first. Those are all the areas for parenteral. Those are all the angles. It should show you the pen, the insulin pen. You can ask her to show you the pen as well on Monday. Intramuscular injections, Z-track method. Now, vastus lateralis is the preferred for which age group? For children, okay? Anything smaller than 3, definitely vastus lateralis. You don't do deltoid and you don't do ventrogluteal, okay? Now, for an adult, ventrogluteal probably is the most preferred just because it's the bigger muscle, right? Especially if you need to give us a bigger volume. You don't want to give into the deltoid. Intradermal, you guys were able to make your little bubbles in the skin? Okay. Okay, so we talked about all these things. The only thing we didn't mention here was checking for its expiration date on each one of the medications you give. Again, don't assume that nothing's going to be expired in the Pyxis, so check for expiration date. Use at least the 2 identifiers before the medication administration. Check for accuracy 3 times and clarify any orders that you might need. Use strict aseptic technique during parenteral medication preparation and administration. So you don't ever leave an uncapped needle sitting on the table. That's going to contaminate the needle and you're going to contaminate your patient, right? And don't ever, and even after administration as well, so you don't risk getting a poke. Okay, we're done there. We have 9 minutes. Let's go really quick here. We're probably gonna have time for maybe 4 or 5 questions. We'll do classic mode. Let's do individual today. Guys, really quick here, talking about the last class, not the last, the previous to the fluid and electrolytes. What is signs and symptoms of a patient suffering from fluid overload? Okay. Swelling. Crackles, good. What else? Difficulty breathing. BP, is it going up or down? Up. Fluid overload is going to increase hyperbilirubinemia. More pressure. Okay, so is everybody there? 17? How many people am I missing? Talking about that, your attendance is here. Emily,
Yeah.
okay, let's get started here. What does 18 mean? You saw that in your slides. That's what you should know, right? After meals, 5 people. Okay. Oh, hang on to the 14. Ooh, look at her, baby. Is it really you? Half-life of 2 hours. Okay, so we have, I'm happy that at least nobody had no clue at the beginning. But we have some work to do, right? So practice calculating some half-life there. I know that maybe we need a little more time with that. Joe Mama. Who is it? Listen.
Don't look at me.
BID.
Why does my phone keep doing this?
Okay, good job. So BIG, don't get confused. Again, ×2 means give it 2 doses, right? Now BIG is twice a day, usually every 12 hours, okay? One during the day and one during the night. Okay, she's staying up there. What does HS mean? QAC, QHS. Very common phrase. Okay, 10 people, I'll take that. At bedtime, okay? So you usually check the blood glucose before meals and at bedtime. Yeah, okay. And she managed to stay up there again. Let this be seen. Okay, good. Only 2 people need work. After meals, good. Okay, Trevor's careful. He's writing.
Calm down, Trevor.
What? Okay, if you guys got this one wrong, I promise I'll give you 2 minutes if you get it wrong. Okay. I'm giving you 2 minutes no matter what. Oh. QG.
Someone seen it?
Good job. Do you have an announcement?
Yeah.
Go ahead. Okay, guys, we're done. Let's see who wins this one. Oh, Joe Mama.
Like extra points.
Half a point.
Alright, I'm okay with that.
Okay. Go for it.
Hi, I'm Hannah. We're having Thursday Thoughts today. It's in the Student Center. So basically, it's just where like nursing students or other majors can come together. We're gonna have like snacks, games, a small little like sermon, short, like 10-15 minutes. You can get, if you're part of SNA, you can get credit for it. And yeah, I would like you guys to come out and join. It's our first one.
12?
Yes, 12 to 12:50, and you can go get lunch and bring it there. Yeah.
Awesome. Thank you, Hannah.
All right. Hope to see you guys.
I wanted to keep playing.
My time is up. I don't want to take you guys' time at all. I have many games planned throughout the semester, so don't worry.
Just gonna go through all your stuff?